The next step is that we are going to open 3 4x4 gauze packages. We are going to wet the gauze in one package with hydrogen peroxide, and we are going to wet the gauze in another package with normal saline solution, and then we are going to keep the third package dry because we are going to be using the third package of gauze to dry the skin around the tracheostomy site after cleaning. So because our gauze is already part of our kit, then what we're going to do is that we're just going to wet one gauze directly to our saline solution here that we made. This one, the first 50% is the hydrogen peroxide, and then the other one with the normal saline. So we're going to keep the remaining one for the drying, and then here the other one that we have here is the slit dressing, which will be used later on as well. Now we are going to open prepare two cotton tip applicator packages. We are going to wet the applicator in one package with normal saline solution, and we're going to wet the applicator in the other with hydrogen peroxide. This will prepare the applicators for cleaning the exposed surface of the outer cannula and the stoma site located under the faceplate of the tracheostomy tube, respectively. So the same way, we're going to use our scissors right here to prepare or dip this right here. Just let it stand so it'll be prepared later. So one with the hydrogen peroxide and one with the normal saline. Okay. Then we are going to open the package or prepare the package of Velcro tracheostomy ties, or cut a length of twill tape long enough to go around the patient's neck 2 times. Make sure to cut end of the tape on an angle. Now, this will allow for quick stabilization of the tracheostomy tube, preventing dislodgement. Cutting the twill tape on an angle allows for easy insertion through the faceplate eyelets. So here, this one right here is our pretend Velcro tie. It's between a Velcro and a twill tape because it has a Velcro lock in it. But anyway, this is already part of our sterile kit. I have already opened it prior and then prepared it together with our sterile kit. Now, after that one, we are going to prepare the package containing new disposable inner cannula if it's available, because it will allow for quick replacement of the inner cannula. Okay, so in our case, we already have prepared our inner cannula earlier, and it's right here. So it's part of our sterile kit as well. So this time we are going to put on clean disposable gloves because the gloves will protect us against exposure to blood and body fluids. Let's go ahead and do it. After putting on clean gloves, we are going to remove the oxygen source if one is present. So right here, our patient is connected to the vent. Stabilize the outer cannula and faceplate of the tracheostomy with one hand, and we're going to rotate the lock on the inner cannula in a counterclockwise motion with the other hand to release it. Stabilizing the base plate will prevent trauma and pain from the stoma. Releasing the lock permits removal of the inner cannula. So we are going to stabilize the outer cannula and faceplate of the tracheostomy with one hand, and we're going to rotate the lock on the inner cannula in a counterclockwise motion with the other hand to release it. Now, stabilizing the plate prevents trauma and pain from the stoma, and also releasing the lock permits removal of the inner cannula that we have right here. Now, continue to hold the faceplate and gently remove this inner cannula that we have here, and carefully drop this in the basin with hydrogen peroxide. replace the oxygen source over the outer cannula. If disposable inner cannula was in place, we are just going to dispose the inner cannula in the biohazard receptacle according to the agency policy. And soaking in hydrogen peroxide basically loosens the hardened secretions, and replacing the oxygen source here maintains oxygen supply to the patient. This prevents oxygen desaturation by maintaining oxygen to our client. So next is that we are going to remove the soiled tracheostomy dressing and place the soiled dressing in our gloved hand and peel the gloves off so that it turns inside out over the dressing. And also we're going to remove and discard the clean gloves and the dressing. So Miss Bear, I'm just going to remove the soiled dressing right here and dispose it. The rationale for that is we are trying to contain the spread of contamination and microorganisms. So the next thing to do is we are going to perform hand hygiene. So to clean the cannula, this is what we will be doing. We are going to don sterile gloves and keep the glove on our dominant hand sterile. Also, we're going to handle the sterile supplies with our dominant hand. Because this will maintain an aseptic technique of the procedure. So let's go ahead and don some sterile gloves. Just suppose this is a sterile glove. Now, after donning gloves, we are going to remove the inner cannula from, right here from soaking solution using our dominant hand. This maintains sterility of the inner cannula. After removing that, we are going to moisten the brush or the pipe cleaner in saline and also insert it into the tube using back and forth motion. The movement of the brush creates friction and helps remove accumulated secretions. Then, we are going to immerse the inner cannula in the container of sterile normal saline solution and agitate it until it is rinsed thoroughly. Immersing the inner cannula in normal saline solution and agitating it removes the hydrogen peroxide, which can cause tissue irritation and debris from the inner cannula. Now, we are going to tap the inner cannula against the side of our container or solution. Tapping the inner cannula against the side of the container removes the excess fluid so the patient does not aspirate it when we reinsert the cannula. Okay. Now this time, we are going to remove the oxygen source using our non-dominant hand and reinsert the inner cannula into the patient's tracheostomy in the direction of the curvature. Now we have to remember to keep our dominant hand sterile and then lock the inner cannula in place securely to prevent it from dislodging. After that, we are going to follow the manufacturer's instructions. Lock the cannula in place by turning the lock into position to secure the flange of the inner cannula to the outer cannula. Lock the inner cannula in place securely to prevent it from dislodging. And then we are going to reattach the oxygen source if indicated. This will provide the patient with the needed oxygen and prevents oxygen desaturation. Now, we are going to clean the stoma under the faceplate with cotton tip applicators saturated with hydrogen peroxide using a circular motion from stoma site outward, and use each applicator only once and then discard it. This will prevent contamination of the cleaned area. So from the stoma outward, discard. From the stoma outward, and discard. And then we are going to clean the top surface of the plate and the skin around it with a gauze pad saturated with hydrogen peroxide. We only have to use each gauze pad once and then discard it. Now, removing the secretions that provides a prime medium for microorganisms growth prevents contamination of the cleaned areas. So we're going to use the gauze soak in hydrogen peroxide first. So we can clean the plate first. Discard. Get another. And discard. And we can get another. Discard. So we are going to repeat steps number 37 and 38 using cotton tip applicators and gauze pads saturated with normal saline solution. The reason for this is that we have to remove the hydrogen peroxide and the debris that can irritate the skin. From the stoma outward. So gauze pad with normal saline solution from the stoma outward, and discard. Now we are going to dry the skin we're now going to dry the skin and outer cannula surfaces by patting them lightly with the remaining dry gauze pad, because this will help prevent skin breakdown and removes moisture, which can promote bacterial growth around the stoma site. Now after that one, we are going to apply a sterile dressing. We are going to use a commercially prepared split gauze tracheostomy dressing of non-raveling material. Now we should never use cotton field gauze because cotton lint or gauze fibers can be aspirated by the client and it can potentially create a tracheal abscess. So here we are going to place our 4x4 gauze 4x4 dressing under the flange of the tracheostomy tube. While applying the dressing, ensure that the tracheostomy tube is securely supported. Excessive movement of the tracheostomy tube may irritate the trachea. So after that one, we have to change the tracheostomy ties that we have right here, or the Velcro collar. We need to seek assistance from another staff member to help changing the tracheostomy stabilizers or ties, because this will prevent accidental dislodging should the patient begin coughing during the procedure. So in here, as for the Velcro method, collar method, because we are using a Velcro right here, for this procedure, we are going to thread one piece of the collar with the Velcro end into the slot on one side of the flange. So we are going to do that. So we're going to tie. And then take the collar around the back of the client's neck, keeping it flat around, and then we are going to thread the other piece of the collar with the Velcro end into the slot of the other flank. So we're just going to take this. Okay, lift your head, Miss Bear. And then we are just going to thread the other piece of the collar with the Velcro end into the slot of the other. Okay, so here's the slot. And of course, we are going to take the second piece of the collar around the back of the client's neck, keeping it flat. Have the client flex the neck and secure the two pieces of the collar together with the Velcro, allowing space for two fingers between the collar and the client's neck. Okay, Miss Bear, can you please flex your head for me? Okay, flex your head, thank you. So at least 2 finger breadths, so it won't be too tight. And then check the tightness of the collar as with this method. So we are going to now remove the old one, the old Velcro tie. Nine, just 9. Hold on. Then we are going to remove and discard our sterile gloves. Dispose the use of equipment in the appropriate biohazard receptacle according to agency policy. We're going to tidy the area because properly disposing the used equipment prevents cross-contamination. So we are going to perform hand hygiene in order to prevent the spread of microorganisms, and then we're going to document all the relevant information, and we are also going to record sectioning, tracheostomy care, and the dressing change, noting your assessments. For evaluation, we have to assess the area around the stoma site for signs of skin breakdown. We also have to evaluate the patient's tolerance of the procedure and note whether there were any signs of respiratory distress. Then for the documentation, we have to document the date and time that we performed the tracheostomy care. You have to note the color, the amount, consistency, and odor of secretions. We also have to document or note the condition of the stoma and skin around the stoma site. We have to note the presence of drainage, redness, or swelling. Also, we have to document the respiratory status, including respiratory rate, depth, and pattern, skin color, and breath sounds. Plus, we have to note the patient's tolerance of the procedure. If problems arose during the procedure or after the procedure, we have to document any interventions that were necessary.